Today as Sir has spoken one end of the spectrum, I am going to talk about the other end of the spectrum, that is low AMH, low reserve, what next? So let's look at the story of this couple, 25-year-old Ria, 29-year-old Raj. They're married since 2 years. They're planning for a baby. She has regular cycles, and when the couple comes to us, we routinely do a ultrasound, transvaginal ultrasound, and what we notice is her antral follicle count is 2 in each ovary. So when the antral follicle count is low, the next step we do is we test for her AMH, and her AMH turns out to be 0.8. So I'm sure all of us are facing similar situations where we are seeing young girls, young ladies, recently married, coming to us, and they have regular cycles. They don't have anything else which strikingly tells us she may have less reserve. But when we put a probe, we see that she has extremely less reserve. And this trend is increasing day by day. We are seeing more and more patients with less AMH. So if I am seeing maybe 10, 20 patients, I'm getting almost 7, 8 patients with a low AMH. So once we counsel her about this, there comes a plethora of questions. First of all, she doesn't accept it. She says, why did this happen to me? I don't have any bad habits. Why did this happen to me? Nobody in my family has this problem. My mom conceived, my sister conceived, then why me? Will I conceive naturally? Do I have to go for treatment? I am young. I just had a very short married life. Or maybe I'm not even trying properly for the last 2 years. Don't I have a chance to conceive naturally? Do I need treatment immediately? You mean to say if there's no time at all? Can't my reserve be improved? Can't you do anything? Can't you give me some medication where you can put me out of this situation? So these are the common questions that we encounter in such a situation. So all of us know that AMH is one of the earliest markers of ovarian aging. I'm not going into the details. It's basically secreted by the preantral, small antral follicles. And routinely we don't test for AMH because if the reserve is normal when we do an ultrasound scan, usually we go ahead with the treatment. But when the AMH, when the antral follicle count is less, generally we test it. But ACOG recommends that definitely it has to be tested for women who are more than 35 years. They have a history of smoking. They have a prior surgery for endometriosis. There is a previous history of oophorectomy, cystectomy, gonadotoxic therapy, or any autoimmune conditions like Hashimoto's thyroiditis and SLE. And as we had a huge discussion about metabolic disorders, any metabolic disorder also, I think AMH has to be tested. So generally more than 2.2, we have good fertility. Less than 2.2, the fertility declines, and anything less than 1.2 actually is considered as less reserve. So there are a few terminologies which are a bit confusing. Premature ovarian failure, premature ovarian insufficiency. So failure is when FSH is more than 40 at an age less than 40, and she actually has amenorrhea. But premature ovarian insufficiency is a part of the spectrum of aging which occurs prematurely. That is, it occurs less than 40 years. When you expect the AMH to fall after 40, it is actually happening earlier. So initially it is occult, where she has regular cycles, she has normal AMH and FSH, but she has reduced fecundity. Then it becomes biochemical, where you see variations in AMH and FSH, but still the cycles are regular. And then it becomes overt, when you even see amenorrhea. So that is a spectrum. And the biochemical part of it actually refers to the poor reserve that we are talking about, because that is where we actually trace, or that is where we actually figure out. Poor ovarian response is when she has good reserve, but she doesn't respond adequately. Say, for example, she had 10 follicles to start off with. We stimulate her in an IVF, but only 5 ultimately grow, or less than 50% response is what we get. And functional ovarian reserve refers to only those recruitable follicles which actually can respond to our gonadotropins. So we have a non-growing follicular pool as well, which will not respond, and we have antral follicle pool, which are actually recruitable. So as the age increases, especially post-puberty, the non-growing follicular pool decreases and the recruitable follicular pool increases. So AMH peaks at the age of 20 to 25 years. And after 25 years, both the non-growing follicular pool as well as the antral follicular pool starts to decline. So this is what happens normally, but we have situations where this occurs at a faster pace in some of the individuals. So this was a study which was published in Journal of Human Reproductive Sciences, which stated that Indian women seeking for infertility treatment face early ovarian senescence. That is, you see a lot of Indian women at the late 20s and early 30s itself who come for infertility treatment having very low AMH. So the reasons, as I've already discussed, is increasing age, endometriosis, PID, obesity, chemoradiotherapy, autoimmune, surgical removal, whatever, all of this. But what about Ria? She didn't have any of these risk factors. So in spite of not having all of this, we still can have a low AMH. Now what are we actually looking at? So it could be something related to lifestyle changes. It could be intangible cultural factors linked to social habits, ethnicity, diet, genetic predispositions, environmental factors like endocrine disrupting chemicals. So endocrine disrupting chemicals, there's a lot of research in this area which is actually lead to increased oxidative stress, early senescence, early aging, decreased AMH. So the world is changing, we are technologically advancing, we are reaching the moon. But just look at this picture. What are we doing here? So 70% of water is unfit to drink in India and 40 million liters of water is contaminated in a day. 25% of the food we eat is adulterated. It is more than 40% in UP, Rajasthan and Jharkhand. We are consuming 40,000 microplastics, breathing 74,000 microplastics per year. Endocrine disrupting chemicals, there's a lot of data supporting that it actually plays a role in disrupting the hypothalamo-pituitary-ovarian axis as well. So this was one study where the fetal ovarian cells were incubated with BPA, bisphenol A, which is an integral part of plastic, which shows that it affected the meiotic progression. So definitely these plastics are something we are getting exposed to. So all of these factors probably in Ria, she doesn't even know that it is happening to her. The food she's eating, the water she's drinking, the environment she's exposed to, the plastics that she's getting in touch with, all of these are causing some changes and she has no clue about all of these. So as Madam has elaborately discussed about the metabolic changes as well. So when glucose, carbohydrate, lipid metabolism, all of them are perfectly fine, reserve is normal. But when there is any changes that is happening and there's a disruption in the metabolism, there is increased oxidative stress which causes early senescence because of increased apoptosis of the follicles that we have. This is a very interesting article which says that the reserve of the lady is predetermined by the health of the mother when the baby was in the womb itself. So exposure of the mother to smoke, diet, obesogenic diet, excessive caffeine consumption, malnutrition, all of these have an effect on the reserve of the baby when it is in the womb. So the reserve of the lady when she is in the reproductive age is actually predetermined by the reserve she acquires in the fetal life itself. So there is so much of connection and there are so many theories to explain what could be the reason for the less ovarian reserve. So this is very common query that many patients also ask me, you keep giving medications for my conception, will I lose my reserve? See, you're giving me medications for folliculogenesis, will I lose my reserve? But actually that's not how it is. Every month a few follicles are getting recruited and that is all that we can play around with. When do we actually suspect poor reserve? So when a patient comes to us with shorter cycles, so she'll typically tell us, I'm getting cycles earlier, maybe 3 days, 4 days, 5 days earlier than what I used to get. And when you do a day 2 scan, you already see a selected follicle, 10, 12 mm follicle. There again, you should suspect that the AMH is less and probably get her tested. So how do you manage now? What do you answer? What do you tell Ria and Raj? What is she supposed to do? So women with POR have a limited reproductive lifespan to conceive with their own eggs. So this forms the bottom line that, you have limited time to conceive with your own eggs. If you want your own biological child, you should do something fast. So early recourse to IVF remains the only option, though it has challenges of higher cost and less than normal success rate, which a normal reserve lady of her own age would have. So early means how early? How early do you want her to go for IVF? So early, does it mean the next cycle she has to come back for IVF? So this was an interesting study where it was done in the COVID time, where we had guidelines of shutting down all the IVF centers because it's an elective procedure. So the main concern was patients with poor ovarian reserve. So are we actually doing justice by waiting for 6 months? Because she may lose her reserve. So this study proved that 180 days of waiting did not actually affect the outcome. So by doing immediate IVF or doing it after 6 months, the number of oocytes retrieved or the live birth did not change. So it's okay. 3 to 6 months is still okay. So this was a study where they said that ovulation induction in IUI was equally effective in normal reserve patients and low reserve patients between the age group of 20 to 39 years. And this was one more study published in Fertility Sterility which says age less than 35 years, ideally ovarian stimulation with IUI in normal reserve and less reserve also had equally good results. So that's the news for our couple, Riya and Raj. You can try ovarian stimulation and IUI over a span of maximum 6 months. If they don't conceive, then proceed for IVF. But Riya is not satisfied. She says, do something and increase my reserve. I still want to conceive naturally. So she says, give me some tablets. Give me some medications where my reserve improves. So can we think of any medications? All of us have read about DHEA. DHEA, will it act? Can you rely on DHEA and allow her to go for a natural pregnancy? So how do these androgens act? Androgens basically increase the FSH sensitivity of the follicles and they increase maybe 1 or 2 follicles that reach the recruitable state. So that's how the androgens act, and DHEA basically gets metabolized to androgen and it increases preantral follicular growth and survival. It increases the sensitivity of the preantral follicles to FSH and increases the number of antral follicle counts. So more retrieved oocytes, better pregnancy outcomes. So it is basically given at 50 to 75 milligram for 3 to 4 months. But evidence is not completely strong enough to recommend DHEA to cause a major change. So whatever studies are there shows that it's not making much of a difference. But these are small studies. We still need a lot of data on this. So the similar adjuvant is testosterone. We usually use testosterone patches when we're doing an IVF. Initial results were that testosterone did help, but now after the T-transport trial, we have realized that even testosterone gel probably is not helping much. Coenzyme Q10 is an antioxidant. Basically, it reduces the oxidative stress, so it prevents apoptosis to a certain extent and probably increases the reserve to a certain extent. 200 milligram thrice daily for 60 days preceding IVF was associated with more retrieved oocytes. But all of these adjuvants do not actually have strong evidence in their support. So you just can't put them on these adjuvants and say, take your time and try naturally. You have to do something and you have to speed in her chance of getting her own biological child. Otherwise, she may have to end up going for a donor gamete. So IVF definitely beyond 40 years, less reserve, that should be the first choice. So all the evidence that we have says younger age, probably you can think of IUI, ovarian stimulation and IUI. So in IVF, basically, these are, I'm just putting it in a single slide because I don't want to go too much into ART at this point. So we have to give a good pre-treatment so that you get a synchronous cohort of follicles so that you have a good outcome. Adjuvants like DHEA, testosterone, CoQ, debatable they are. Ovarian stimulation, the recent ISHRE guidelines tell us that either antagonist or agonist, it doesn't matter. I mean, both of them have equally good outcomes. Mild stimulation, don't cross beyond 300 IU. Just because they have less eggs doesn't mean you dump gonadotropins and you get more eggs. You can only stimulate what you see. And growth hormone also, there is some contradicting data. During stimulation, growth hormone 2 or 4 international units have been tried. Dual trigger helps, and you should also be counseling for embryo pooling and dual stimulation. That is, stimulate in 2-3 cycles, pull up all the embryos that you get and go ahead for a transfer. Or a dual stimulation, that you stimulate in the follicular phase, stimulate in the luteal phase, pull up the embryos and go for transfer. So all of these can be tried in a patient with less reserve. But everything said and done, she is definitely going to have lesser chances compared to another female with normal reserve of the same age. So what about autologous platelet-rich plasma? So there are some studies which say that by injecting autologous platelet-rich plasma into the ovaries, there has been an increase in AMH, a fall in FSH. But again, data is not good enough for us to recommend it at this stage. And what about in vitro activation? This is also still experimental, where you take out fragments of the ovarian tissue. you add some activators, promoters, and then you retransplant the ovarian fragments into the body. But still, we need a lot of evidence on this. Stem cell therapy, again, this could be a promising future for patients with low reserve, where stem cells can move into the ovarian cell line, and probably this should be the way forward, but it requires a lot of research and a lot of papers on this. So of late, definitely we are seeing a lot of patients with less ovarian reserve, because basically patients are postponing their pregnancy, because it's a biological clock which we can't stop from ticking. But of course, prevention is always better than cure. So can we really stop the biological clock from ticking? Yes, we can, if we do opt for an egg freezing and oocyte cryopreservation. So if you want to prevent somebody to land up in a stage of less reserve and they're struggling to have their own biological child, counseling them for this option is always a great thing to do. At the age of 30, we have only 12% of the eggs remaining. At the age of 40, we have only 3% of the oocytes remaining. And the chances of aneuploidy also increases as age progresses. So this is good data for us to tell our patients that, yes, if you want to postpone your pregnancies, freeze your eggs, right? So now, if supposing a patient is agreeing to, yes, say I want to go for social egg freezing. So when exactly do we ask her to freeze the eggs? How many eggs do we freeze, and what are the chances of live birth? So she says, okay, can I just freeze my eggs and plan whenever I can? Do you guarantee me a pregnancy? How do you counsel her? So optimal timing, ideally when the reserve is best, when the fertility is best, if you're able to preserve the eggs, it is ideal. Earlier the better. But data has told us that it is not going to be very cost effective, and reutilization rates are less. So if a patient comes to us, say around 35, 36 years, and she says, I want to freeze my eggs, will you do it? They say yes. Even up to 37 years of age, if the patient wants to postpone pregnancy, still freeze whatever eggs that you can obtain, and she can still wait. The number of eggs to be frozen, it depends on so many factors like maternal age, ovarian reserve, reproductive goals, paternal health, and all of these. 15 to 20 is ideal. So you need 6 oocytes probably to get a blastocyst in an average fertile couple. So say supposing you have 3 blasts, 4 blasts, maybe 15 to 20 should be the number. But again, it depends on multiple factors. And this was one graph where they said that based on the age, you can calculate the number of mature oocytes you should freeze to get one live birth. My take home would be assessment of ovarian reserve by transvaginal scan is of prime importance. I have seen so many patients who come to us with a diagnosis of PCO, and when I put a probe and see, it will actually be poor reserve. So when you look into the details, it would be some transabdominal scan done by a radiologist. No offense, I'm not saying, it's just no offense, but I'm telling you that this has happened several times. Doing a transvaginal scan by yourself is very important. If you're not doing it, sensitizing your radiologist to do a transvaginal scan when they're doing an assessment of a fertile couple is extremely important. Ovarian stimulation and IUI have equally good outcome in less reserve patients when the age is less than 35 years. So less than 35 years, give them at least 3 to 6 months time, let them go for IUI. Limited reproductive lifespan warrants early IVF, but don't scare them, you have to do IVF next month, otherwise you have to go for donor gametes. So, they're already in so much of shock. Don't put more stress on them. That stress is going to do more harm. Role of adjuvants like DHEA needs to be established with further clinical trials. So thank you so much for your patient listening. And I also take this opportunity to invite all of you to the South Zone IMSICON conference. We have a registration desk outside. Just if anybody is interested, please do register yourself. And we are doing this in association with Vijayawada Society. It's going to be a great academic feast.
Thank you, Suma, Varsha.